Okay, this is part 3 of buprenorphine treatment, a training for multidisciplinary addiction professionals. I'm now going to turn this over to your presenter, Dr. Lauren Broyles.
Thank you, Chris. Thank you, everyone, for joining us for this final segment of the training. Excuse me one moment while I adjust this. There we go. The modules today are on coordinated care and counseling buprenorphine patients. We're going to start with coordinated care and then move into buprenorphine-specific counseling issues. A lot of the material in Module 6 I'm presuming, is familiar to people. So I'm going to move fairly quickly through that second module, and we may actually finish a little bit early today and have plenty of time for questions. I know that Christine sent out some of the information that Dr. Silbert and I had gathered after the last session regarding questions about breastfeeding and buprenorphine. That was sent out via email. If you did not receive that information with some of the references and determination that it is safe to breastfeed, if you are a postpartum woman, please let Christine know and we can forward that to you again. Additionally, if you have any other questions about that specific issue, please feel free to ask those during our question session. I'd like to use the same format that I've used before, which is to take a break, a 5-minute break about halfway through. One moment, please. Okay, thanks. Everyone should be able to see the proper screen at this point. I'm going to start first with the topic of coordinated care, which is an important part of buprenorphine treatment. The patient who enrolls in this type of treatment is obviously facing a lot more than just a medical issue, because the disease of addiction affects all aspects of a person's life, and all of the consequences and recovery supports have to be addressed if substance abuse treatment is going to be effective and recovery is going to be sustained. Since a variety of different professionals from different agencies and different professional disciplines are going to be participating in some aspect of treatment or patient care, it's really important to think carefully exactly about how that care can be delivered in a coordinated and consistent and ultimately patient-centered or patient-friendly approach. That's what we're going to be exploring in this module. So effective coordination of care combines the strengths of various systems and professions, including physicians, addiction counselors, 12-step programs, and community support service providers. The roles of the different providers may vary by state depending on the identified scope of practice for each profession. And that's really one of the key things to remember, is that while we don't want to have siloed care, we do want each discipline or professional to remain within their proper scope of practice. While previous opioid treatment types occurred only in the context of federally regulated programs, so I'm talking about methadone treatment in that respect, buprenorphine extends this option into the physician's office, and that really puts the onus on the physician to make sure that he or she has the coordinated system of care so that they can fully benefit from the medication that they're being prescribed. We know that treatment is most successful when there's comprehensive and coordinated services and a collaborative approach to care. It's really important in this instance to have assigned release of information to prevent delays in communication between multidisciplinary professionals and the treating or prescribing physician. If you, as a non-prescribing clinician or professional, see things like signs of withdrawal or ongoing substance use, obviously you have to bring the physician into the loop immediately and not go beyond your scope of practice. If you're ever in doubt, refer the patient back to his or her treating physician. A little bit more specifically, in this module, we are going to talk about developing strategies to form linkages between physicians who are authorized prescribers and the rest of the substance abuse treatment team. We're going to elucidate or talk a little bit more about the role of addiction programs and professionals in providing this type of medication-assisted treatment. Talk about other professionals who have a role in this whole continuum of care. Identify key issues in coordinating care, and then some of the key issues in managing care specifically for buprenorphine patients. So we know that coordinated care is critical for effective treatment, but it's critical that service providers adhere to their local and federal laws that pertain to confidentiality and HIPAA, which is the Health Insurance Portability and Accountability Act. This is going to include, but definitely not be limited to, ensuring that patients want that collaboration to occur and that they provide signed releases of information to allow for easy and effective communication that's streamlined between all of the professionals who are helping them. So the roles of the physician in this team are screening, assessment, diagnosing opioid addiction, providing some degree of patient education, actually prescribing buprenorphine, urinalysis testing, and recovery support. The medical system has physical health as its primary goal, and so in that context, the physician may focus on alleviating the discomforts of withdrawal by helping the person taper off of opioids or providing ongoing buprenorphine medication to help stabilize them. And they may focus on also the longer-term goal of helping that person maintain abstinence from illicit opioids. The physician's choice of treatment really needs to be determined by the intensity of the intervention that's necessary to fully support that person as an individual in their individualized recovery plan. And as most of you know, the whole continuum of treatment covers intensity levels from episodic office-based therapy or encounters all the way through to intensive inpatient therapy or rehabilitation. The rest of the multidisciplinary team is also providing some overlapping functions, but some that are a little bit more unique to people working in these types of roles. The rest of the multidisciplinary team is also engaged in screening, may be engaged in assessing and diagnosing opioid addiction. They're more likely to be the providers who are providing psychosocial treatment, more comprehensive patient education, referral for treatment at a higher level if that's needed, urinalysis testing, recovery support, and then this role of case management and coordination. It's a pretty complex set of roles that are all interacting, roles and people, and the various treatment services are going to come under different segments or auspices of the healthcare system. Some are directly affiliated with mental health agencies. Some function as independent or separate systems. It just really depends on what your local situation is. But it means that funders and client referrals and staffing and facilities and all of these different aspects of the treatment program are going to vary across the agency. The Center for Substance Abuse Treatment, which again is one of the partners in this, excuse me, in this NIDA-SAMHSA blending partnership, has this vision that at least publicly funded addiction treatment and recovery services in this country are based on the idea that treatment and recovery have a solid infrastructure that's at the same time flexible enough to be tailored to people's individual needs. They really advocate for community-based programs to be able to assess the needs of their patients and to be able to do that comprehensively, match people up with what their individual needs are with appropriate interventions that are going to support them, but also provide some degree of support for their families or for their significant others. CSAT also envisions that ideally community-based treatment services are able to provide an array of options along a whole continuum of care. And really they want people to be able to determine and demonstrate outcomes from their treatment programs. Ultimately, The idea is to get people engaged at the appropriate level of care, and there's really no wrong door into treatment. In terms of the role of the community support provider, they're an important link in this whole network or mosaic of services that are available to the person in recovery. Some of their roles, again, are going to overlap, and some are different. We've seen screening, assessment, referral for treatment, and recovery support before, but one of the unique roles here is meeting some of the ancillary needs of the patient. There's also a role for 12-step programs specifically, and this may be a little bit counterintuitive to what some people might initially think, and so I want to spend a little bit of time talking about it here, and then we do cover it in the next module as well. Most of you can probably imagine, or you've experienced firsthand, that the stigma that's associated sometimes with medication-assisted treatment or opioid maintenance therapy in particular may be an issue at in some 12-step meetings or 12-step communities. And people are likely to need some coaching in this area, patients who are on treatment, as well as perhaps larger members of the 12-step community who are not receiving buprenorphine treatment. Some of your patients may have had negative experiences in the past because they were taking either medication for their drug addiction or, in some instances, even for psychiatric disorders. Some 12-step programs do accept people who are taking medication, and on the other hand, some 12-step program participants don't make a distinction between drugs of abuse and appropriately used and prescribed medication. And so they feel uncomfortable and even intolerant of folks who are taking medication as part of their recovery process. I do want to point out that AA has developed an AA-approved publication called the AA Member, Medications and Other Drugs. It's worth taking a look at if you're not familiar with it. Ultimately, each of you is going to have to develop an effective approach that you feel comfortable with for addressing the issue of your patients who may be interested in or could benefit from 12-step who are taking buprenorphine. So people might, one way to handle this that has come up in the past is that people may decide to coach their patients that there's no need to disclose their medical history or medications that they're taking in public settings like 12-step meetings. Some people opt to take the route of linking patients up with 12-step support people who they know are understanding and supportive of others who are using medication-assisted recovery modalities. A third option, one of which is what we've used at the VA in Pittsburgh, is to have special support groups for patients who are participating in buprenorphine treatment, which reiterates or relies heavily on 12-step concepts, slogans, and modalities. So those are a couple different ways that people have chosen to sort of reconcile these two potentially conflicting treatment and recovery approaches. But I'd be happy to hear some more during the question and answer session if you all would like to share any. In fact, actually, we're doing well on time now. Has anyone in the audience had experiences either feeling that rub or that disconnect between buprenorphine and 12-step, and if you have found a way that feels comfortable for you individually or for your treatment center to address that, can you share those in the question and answer dialog box?
We don't have any questions yet, but I wanted to let you know that Dr. Chaudhary is available. Dr. Chaudhary, can we hear you?
Yes, I can hear you. Can you hear me?
Yes, it's a little bit faint,
thank you.
but yes, thank you for joining us.
Sorry, I had a little bit of trouble getting in, so I got a little bit late.
Yeah, that's perfectly all right. Do you have any comments in addition to what Dr. Broyles has been discussing?
the recovery support parts?
I was wondering if you or anyone else in the audience had any particular experiences with the potential issue of reconciling buprenorphine treatment with 12-step recovery approaches, and if people had experiences of successfully integrating those two, or how people in the audience had handled that in the past.
As for myself, I have the direct experience of prescribing buprenorphine, particularly on an inpatient detox level. And people are, in that setting, also attend 12-step meetings. And I do not have any kind of knowledge that there was any kind of issues with people being on buprenorphine and not being welcome or could not participate in the 12-step program.
Okay, so that's good to hear. So in your inpatient acute detoxification phase, that had not been a problem. Those two were successfully packaged in the same treatment program.
Great, yes.
Okay. I do have a couple people who typed in some comments. One says, we have been encouraging our members to utilize the SMART, S-M-A-R-T, groups due to the disconnect with the traditional 12 steps. Other says, a few good treatment facilities have their own 12-step meetings for their clients. I have two workbooks, one designed for women and one designed for men, and these are 12 steps applied individually rather than in groups. And it looks like two more. At my agency, we developed an on-site group for Suboxone clients to gain support. In addition, we have had meetings available for family education and support. And then this last one says at my agency, we also refer people to online meetings.
I'm jotting all of these down as you were reading those, Christine. These are really fabulous ideas, and some of these I hadn't heard before. It's wonderful to hear that people are being proactive and clearly responsive to the needs of patients, being creative so that you can not only address some of these issues, but apply some of the same concepts and make those accessible to not only to patients but to their families. So that's really great to hear. I jotted all of those down. The online meetings is a wonderful idea. Thank you. So this slide here gives just a quick snapshot of the whole, whatever metaphor that you want to use, the web, the network, the mosaic of care. And you can see all of the people that are involved. I think here specifically we see for the first time the role of nurses and pharmacists really highlighted in this particular grid. But it really does cover a lot of the different roles and professionals, and speaks to the way that care is not only complex, but people have to make sure that all of the involved systems and all of the key players are actively engaged in care coordination. I'm imagining that most of you have probably had some interprofessional connections develop across agencies just informally, where one staff member becomes familiar with the programs or the services that are available in another agency, and sometimes then staff members and even the agencies themselves can work closely together to mutually benefit the patient in overlapping or complementary ways. The roles, the one thing I want to say too is that the role of addiction counselors and community support providers may vary by state, depending on what the regulations are. In some states, for example, addiction counselors are able to do some of the diagnosing or diagnosis determination. It just really depends, and it's important to know your own scope of practice regulations in your state. Overall, though, the addiction counselor in most states does not formally diagnose opioid addiction, and at this time, the only folks that can prescribe buprenorphine are physicians. So ultimately the physician is going to confirm any diagnosis that is made prior to his or her formal evaluation of the patient before executing a prescription for buprenorphine. If you're not already familiar with the SAMHSA physician locator service to find a physician in your state who's authorized to prescribe buprenorphine, I encourage you to go to the website. SAMHSA provides this registry of physicians who have received the waiver and who are then authorized to prescribe buprenorphine. Patients as well as treatment providers can locate the specific physicians in their area who are accessible. If there aren't any physicians within a local community, you can also attempt to recruit a physician who's willing to pursue the waiver process if there'll be a sufficient number of patients to warrant that effort. It's also important to know that some physicians who are authorized to prescribe buprenorphine may choose not to be listed in the SAMHSA directory, and that's there are a lot of different reasons for that. Some people want to restrict the size of their buprenorphine panel or have some other internal professional rationale for doing that. But overall, just know that the number of physicians who are listed in the locator may be an underestimate of the actual number who are authorized to prescribe buprenorphine in your area. This is a screenshot of the locator, and you can see that you can search by state. So there are some challenges for the rest of the interdisciplinary team, and I think these have come up at certain points along the way, reflected in some of the questions that we've had so far. As I mentioned first, not all physicians who are actually trained and certified have consented to be in that locator, and so community outreach and those interprofessional collaborations and awareness of who is a prescriber is important. The second bullet really speaks to the fact that out of all the research that's been accumulated on the effectiveness of treatment for alcohol and other drug use, demonstrates that it's efficacious for treating substance use disorders, that it has a lot of economic and health and social benefits for individuals and also for society in general. But at the same time, we know that substance abuse treatment hasn't yet been mainstreamed into the healthcare delivery system. There is still a huge disconnect between mental health services and primary care or other medical services, and it's not part of routine primary care at this point. So a lot of patients who are opiate dependent are typically not engaged in coordinated primary care in the mainstream medical care system, and that may change with the continued push for primary care medical homes or primary care mental health integration. But at this point in time, a lot of patients still rely on receiving episodic care in acute or emergency room settings or minute clinics, places where they can quickly access care. And so in those settings in particular, it's really difficult for providers to connect people to other community-based recovery support and treatment services. Both one of the blessings as well as one of the potential curses of buprenorphine treatment is its accessibility in office-based settings. And I said one of the potential curses because it really means that it's setting the bar high for a new level of collaboration between physicians and the rest of the community treatment service network. It's more extensive and really places a lot of that onus either on the physician or on the patient to access some of the services that are available in more traditional opioid treatment programs, and speaking specifically about methadone, where the patient receives his or her medication each day in the treatment setting where other ancillary services are often available. The fourth bullet point is also one that people have mentioned during some of the question and answer sessions. Many insurance programs do not provide reimbursement for buprenorphine. Some provide reimbursement for buprenorphine, but not for the counseling. And so ultimately, both prescribing physicians and the rest of the treatment team are going to need to work together in administrative partnerships so that the medication is available to people who need it on an ongoing basis. There are also some barriers to effective care coordination across disciplines and across settings. These include misunderstanding people's respective roles, conflicting goals for treatment, goals and priorities, restrictions on confidentiality and sharing of information, control issues and turf wars. I'm sure everyone has encountered these to some extent before. And then in some respects also a misconception of what other people's professional perspectives are about the, again, can go back to the notion of shared priorities and shared goals for treatment. On the flip side, some of the attributes of care coordination when it's successful and when it works well include familiarization with the roles and the procedures and the organization of one another's agencies and their offices. And it really allows people to be able to anticipate what the effect of their actions are going to be on other team members. And this is something that may seem self-evident at first, and people are probably, some people are maybe nodding and saying, well, yeah. But it's really important not only to understand what the roles are in your treatment team, but to have some familiarity of how other agencies work. And we get so immersed in the day-to-day responsibilities and needs at our own facilities that very often the last thing that we can think about is understanding how roles and procedures work at other facilities. But it's really critical to be able to make appropriate referrals or to collaborate and move the patient to the appropriate level of care or resources that they need. Another key component is ensuring that there's ongoing and effective communication across professions. And again, we hear this a lot, and it's much more difficult to do in practice. Collaboration depends on effective communication, and very often effective communication depends on having appropriate support so that collaboration can happen. If you're going to be effective at communicating, then you need to be having regular meetings, regular reports, memoranda that are both formal as well as going on in informal communication channels as well. And feedback is important so that people can close those loops and know that patient needs are being taken care of. Speaking back to what I was saying at the beginning about knowing professionals and roles in other agencies, that personal contact is really important. People are more likely to talk with and listen to and collaborate and go the extra mile for other professionals that they know and that they respect and that they've had positive interactions with. It also helps to provide some intermediaries for when you get into a difficult situation. You have others that you can call upon to help navigate those sticky situations. So in closing, counselors who, or other professionals who develop experience working with buprenorphine patients provide a critical part of the treatment package. But unfortunately, a lot of members of the medical community are not familiar with the array of support, the quality of support, and the complete treatment package that's necessary. And so there needs to be reaching out towards one another on both ends. There are physicians who want to be able to provide buprenorphine treatment for addiction but don't have an adequate sense of all the available resources. And so in some cases, it's worth treatment providers thinking about outreach to physicians. And I wanted to close this module with hearing about any creative ideas or other practices or processes that people had used to help set up those linkages in instances where you don't have a prescriber on site. Or does every site have at least one prescriber in-house, so to speak, or on site? Can people speak a little bit to that?
I think this is Dr. Chaudhary. I will add one thing in terms of the challenges for this coordination. Sometimes, as I mentioned in my experience as a provider in an acute setting, it's hard to get that. The piece that I find missing is the coordination between the inpatient services and outpatient when somebody needs to be transferred and may be continued on the medication, on buprenorphine. What happens in those kind of situations, what we do is simply detox and have to leave it on the individual to look for other options, including to get somebody who would prescribe. So I don't know how much this problem is present in other areas, but even in urban areas, I can see that as a problem that still exists.
And you bring up an interesting point. The majority of my experience is in substance abuse consultation liaison work in the general hospital, and I can tell you that it's the same situation often when patients are, say, coming into a general medical setting for whatever hospitalization and are receiving buprenorphine. Folks in the ER have no idea what this is or how to manage it, or I thought a lot in the trauma setting as well. And so it becomes an issue of making sure that people are appropriately and adequately dosed when they come into the inpatient setting as well. And there does seem to be that disconnect in continuity of care across settings.
And there is another one area of coordination between, if there are two physicians, one prescribing buprenorphine and another physician prescribing other psychiatric, or a PCP prescribing non-psychiatric medications, that coordination is sometimes kind of difficult. So what we do in community care, we try to have our care managers kind of follow up and try to encourage the providers to communicate so that that part can be achieved.
So the case managers really serve as that liaison or linchpin kind of role that helps ensure medication
Yes.
reconciliation and some of those shared treatment goals.
Yes.
That makes sense.
This is Chris, and I have some comments that people have typed in. The first is, we developed a letter of the local needs with statistics and formed a task force. The letter was sent out to all local physicians. And then second person said, in the process of setting up a Suboxone program, looking to have MD or a DO prescribe Suboxone and then have a pharmacist and nurse monitor the medication on a weekly or monthly basis. Information is then going to be relayed to the physician on a weekly basis. Another says, we do not have an on-site provider and send status reports monthly to providers. The main issue in this is what can be discussed and what can't without violating confidentiality of clients. Also, at times it appears as though relapse is sometimes approached punitively by prescribing doctors rather than therapeutically. And Okay, I think this is a more detailed response to an earlier comment. It says the task force listed above was formed by sending the letter of need to all significant members of the community, including hospitals, the legal system, DPW, and the recovery community.
So again, it really sounds like people have come up with some innovative strategies for addressing not only some of the logistical barriers in terms of being able to generate reports or generate outreach letters and share information across settings, but to deal with some of those conceptual issues as well, where people mentioned, someone mentioned the one setting having a supportive approach to relapse and another having a more punitive approach. And it really sounds like people are already thinking about all of the different arms, all the way out to DPW and the legal system as well, that really need to perhaps be exposed to this same training here to at least get some basic familiarity with buprenorphine, as well as other treatment modalities within substance abuse as well. Thank you. It's really nice to hear the array of strategies that people have come up with. What I'd like to do now, since we're ending here, the Module 5, I'd like to take a 10-minute break so that people can do email or take care of personal business. And I have, let's see, 2:42 on my clock, so we'll resume right at 2:52 Eastern Time. And I'm happy to take other questions if you'd like to enter those into the box now. Otherwise, we'll resume at 2:52. Thanks. Okay, I'd like to go ahead and get started. This is the final module in the training. Again, this is counseling buprenorphine patients. And as I said before, Module 6 has a lot of redundant information from some of the other modules, and it also has a lot of information that I'm assuming people are already familiar with, given our audience. Things like basic recovery and relapse concepts like triggers and cravings. So a lot of that material I'm going to go over rather quickly or not at all. But if you do have questions or need clarification, again, I anticipate having ample time at the end for questions. So please don't hesitate to pop the questions into the question box, and we can address those at the end. This final module is intended to specifically address issues that are associated with counseling buprenorphine patients, but it has a lot of extra information. It is going to include a little bit on needs assessment, patient monitoring and management, and then some various counseling strategies that can be used when you're providing adjunct psychosocial treatment for people. At the very beginning of the training, we went over some of the myths about medication-assisted therapy. And some of you may remember these myths back from Module 1. The notion that patients are still addicted when they're using buprenorphine, that buprenorphine is simply a substitute for heroin or other opioids, prescription medications in particular. The third myth is that providing medication alone is sufficient treatment for opioid addiction. And the fourth was that patients are still getting high. What we're going to cover to counter some of those myths are really the comprehensive counseling goals for buprenorphine patients. So specifically issues in opioid recovery, cravings and triggers. We're going to go back to some special populations, particularly one we haven't covered in very much detail before, that being patients with concomitant psychiatric disorders. And then we're going to talk about some of the specific buprenorphine-related patient management issues. So some of the issues in recovery that we're going to talk about are, we just came out of talking about 12-step meetings. And most of you probably know that introducing patients to 12-step programs or even getting people to try their first meeting is really a coaching process. And that as professionals, we have to consider some of the different scenarios that people are going to encounter when they actually walk through the door and attend their first meeting. Ultimately, patients who are receiving buprenorphine treatment need to be encouraged to find a sponsor who's going to be supportive of their decision to use buprenorphine as part of their overall treatment plan. Counselors are also essential in providing that ongoing patient education about the importance of the additional things that people need to do in early recovery to support relapse from occurring. This includes things like disposing of any related drugs and paraphernalia, helping people develop ways to address their patient-specific triggers and cravings, understanding general addictive properties of various drugs, as well as addictive behaviors and thinking. And then collectively, all of these strategies in early recovery help people avoid relapse drift. With respect to the third bullet, we know that treatment should be delivered within a formal structure, again, where people can access all of the adjunct services that they may need. And again, bullet 4 just reiterates the point that relapse prevention is not a matter of willpower. It's a matter of learning a new skill set and learning about yourself through a series or a process of learning the skills necessary to avoid picking up again and be able to sustain that over time. I'm assuming that most people are familiar with the variety of things that can serve as triggers for our patients, both with respect to their drug of choice as well as other secondary drugs. One of the important things to remember is that it's going to be an ongoing process to help people not only identify their triggers, but deal with any ongoing exposure to triggers that may be unexpected, and then how to deal with those triggers in a different way when they come up. We know, again, that there are internal and external triggers, internal being the feelings or the emotions that set people off back towards use, and external triggers are things like parties and liquor stores and driving past a dealer's house, having payday, or even a certain time of day. And again, an important part of early treatment in particular is stopping that craving process. So to be able to do that, you have to be able to first identify your triggers and then prevent exposure and returning to ways that you previously dealt with those. We know that the whole process, the whole chain of events is really a process that all kind of runs together and cycles through, and ultimately the ideal way to deal with the process is to not let the chain reaction start in the first place. And so for a lot of patients, stopping that thought when it first begins helps that escalating or that domino effect, preventing it from building into a craving. You all are probably also familiar with a lot of the different thought-stopping techniques to break that initial step in the chain, be it visualization, snapping with something, like a rubber band around the wrist, relaxation and breathing exercises, or calling a friend, be it a counselor, a sponsor, a friend or family member, someone who can help coach people through those tricky times. Most opioid-addicted patients have complicated lives, and they can recognize the physical components pretty easily of their opioid dependence, but very often they may not have a sense, particularly in early recovery, the entire breadth or the scope of the disorder and all of the changes that they're going to ultimately need to make. And so I'm assuming that most people are doing comprehensive and thorough needs assessments to help all patients, but in particular buprenorphine patients who may be receiving their medication in an office-based setting, really look beyond the immediate problem of the physical dependence on opiates and really looking to some of those issues that may come up that hadn't been previously thought about as playing a role in addiction. And this is really where the addiction professional has the fullest sense of all the pieces that are going to need to go into the recovery plan and be able to address any of those gaps. We know that recovery is more than just medication, and of course a lot of patients who are taking buprenorphine may feel that once they've dealt with the physical aspect of their opioid addiction, they've received a medication, that they don't need a whole lot of additional treatment in the form of psychosocial counseling. At the same time, the addiction professional on the flip side needs to be aware that ongoing medication adherence is going to be really important for the patient to be taking the medication correctly and as prescribed and avoiding any temptation at diversion. Bullet 2 is really a sticky point that has come up a number of times during our training. We know that despite the fact that physicians must have the capacity, is the lingo in the legislation, with capacity being the sticky wicket here in terms of exactly what that means, but they have to have the capacity to refer their patients for additional counseling. They may not do so, or they may not have adequate knowledge of providers that do a good job in their local community. And so we're back to that issue of providers and prescribers needing, treatment providers and prescribers needing to form these effective linkages and be able to trust one another with their respective portions of the treatment plan and collaborate effectively. One of the third most prominent patient management issue does involve the establishment of contingencies for patients who fail to follow through on referrals. So even in instances where providers are working together and collaborating and attempting to meet the needs of patients, sometimes it's patients themselves who aren't ready or willing to engage in the counseling or psychosocial portion of the recovery process. In terms of treatment monitoring, the overall goals for treatment, this is pretty standard regardless of medication-assisted therapy. Typically the goals are no illicit opioid use, no other drug use. This can include alcohol use, but different treatment programs handle this issue of alcohol use differently. It's just important to keep in mind that possible alcohol use needs to be assessed regularly, and the goals for treatment really need to be agreed upon by everybody in the picture, so the physician, the substance abuse counselor, the whole team, and the patient as well. Obviously, some of the other goals of treatment are adverse medical effects, adverse behavioral or psychiatric effects, and the last two bullets are ones that may be a little bit more specific to buprenorphine. So responsible handling and storage of the medication in the home, and medication adherence, in particular, taking the medication properly and as prescribed. Weekly visits, and in some cases even more frequently, are essential for, I'm changing the slide, not just important to, but essential for providing ongoing counseling to address barriers that people, real-life barriers that people may encounter, be it transportation and travel issues, child care, different work or employment obligations, and also to provide ongoing counseling about specific recovery issues, not just addressing logistical barriers, but a lot of the psychosocial processes that are occurring. Treatment monitoring also, again, includes adherence to the dosing regimen, people's ability to safely store and take the medication, and then to properly evaluate treatment progress and encourage people so that they remain engaged in what they're doing. If medical issues come up during this phase of treatment, be they specifically related to opioid dependence or withdrawal, or related to another chronic condition that someone, or acute condition that someone may have, again, it's essential to refer those questions back to the treating physician. We talked a little bit about urine toxicology testing in a previous module, where we were saying that buprenorphine does not show up as positive for other opioids. You need to specifically test for that. It's not in the NIDA-5 panel. It's important for urine tox screens to be administered at least monthly for all of the substances that are relevant for that particular individual, and to assess treatment efficacy. Lots of different people may be conducting the urine testing. It could be the physician, the counselor, or other staff. And it's really designed to be an additional tool to prevent drug use. It's a standard procedure that's meant to help treatment and isn't designed to be a surveillance tool that's based on the assumption that people are being dishonest or recalcitrant somehow. With respect to bullet 2, about tapering buprenorphine while psychosocial services are ongoing and different phases of recovery are enhanced, it's ultimately not the addiction counselor's professional decision to discontinue buprenorphine or not. However, it's critical that the prescribing physician have some of the addiction counselor's perspective on that, and a sense of how well the patient is meeting treatment goals and adhering to other facets of the treatment program. With respect to bullet 3, again, this notion that the treatment team needs to work together to prevent involuntary termination of medication as well as psychosocial treatment, and essentially people leaving or disengaging from treatment. Ultimately, in the case that if that happens, then it's really up to the treatment team to make appropriate referrals and attempt to re-engage the patient. Physicians are the ones who manage buprenorphine if it is being tapered so that the patient has minimal discomfort during any withdrawal procedures. I'm going to return for a couple moments to talk about some special populations. First, we're going to talk about patients with co-occurring psychiatric disorders, but then also pregnant women. A lot of that's a review, and also touch a little bit more on adolescents and buprenorphine. So patients or clients who have concomitant psychiatric disorders may have conditions that range anywhere from common anxiety or depressive disorders to personality disorders or much more severe mental illness. Sometimes, of course, both the effects of acute intoxication from substances as well as people who are having withdrawal, those symptoms can all mimic psychiatric symptoms. And so it's really important for counselors and physicians to get a good sense from the patient of what might be going on, how long the symptoms have been occurring, how recent any additional drug use was, and the amount of drug use that a patient has been engaging in before making a psychiatric diagnosis. It also is helpful for counselors who have been away from this realm for a while to review, parts of the DSM-IV that include substance-induced disorders, just as a refresher, and just, again, essential to maintain ongoing consultation between the prescribing physician and other health providers. Any of symptoms that would suggest further action would include, obviously, suicidal thoughts or plans, mood swings, extreme changes in mood, extreme changes in sleep or just typical activity patterns, people feeling hyperactive, paranoid, having auditory, visual, or olfactory hallucinations, being unresponsive, or having other cognitive changes or confusion. These slides are actually almost identical to what we covered before with respect to pregnant women. I'm just going to quickly reiterate these main points, that methadone maintenance is still the treatment of choice for pregnant women who are opioid dependent, and that opioid withdrawal is rarely recommended during pregnancy. Buprenorphine is not currently approved for use in pregnancy, but it may eventually be more widely used and approved for this particular population. Again, it's still a Category C medication. It means it has not been approved for use in pregnancy, but we know that a lot of the clinical trials are suggesting that it may indeed nonetheless be an excellent option for pregnant women. Randomized trials are still underway to assess its efficacy and safety. Some of those have, most of those actually have taken place outside the United States. And as we mentioned last time, excuse me, other multi-site trials are still in progress to determine the effects of buprenorphine not only on the pregnant woman and her comfort and safety, but the neonatal abstinence syndrome and safety for the newborn as well. This slide just summarizes those considerations with respect to pregnancy. Again, if it's ever used in this situation, it's recommended that it's the monoproduct only. As you received in the email, buprenorphine passes through to breast milk in minuscule amounts, and then as the infant is taking breast milk in orally, any that would pass into breast milk would then be neutralized, isn't the right word, rendered even less, having less of an impact because it's going to be encountered by the patient, by the baby's digestive juices. So the recommendation for both the physical health of the infant as well as the ongoing bonding between mother and child is for postpartum opioid-dependent individuals who are taking buprenorphine to indeed breastfeed. Again, I have some additional resources on that if you would like to have those.
I think I'm sorry, it is the buprenorphine, because of its poor bioavailability, which is not available for absorption or very poorly absorbed through the GI tract, and that's why I use sublingual here. So even if it's present in the breast milk, it goes very little into the system of the child.
Exactly, yes. And then we had talked a little bit in a previous session about the different patterns of absorption sublingually versus, PO through the gut and then intravenously, and what the implications were for those. But you're right, as you start to think about the process, very little is going to even pass through to the breast milk, and then very little would then be absorbed through the GI tract of the infant.
Yes.
Yes. So we haven't talked a lot about opioid-addicted adolescents and young adults. In this case, I'm primarily talking about patients 16 to 25. I know that some people in the audience do serve this population, so I wanted to spend a couple minutes talking about adolescents and buprenorphine. In general, states have different requirements for admitting patients who are under 18 into addiction treatment, so it's important to know what those regulations are for your state or your municipality. Overall, buprenorphine is approved for use in opioid-dependent patients who are 16 and older. There has been some research that's conducted through the NIDA clinical trials network that has demonstrated that it can be not only safely used but also effectively used. There have been various trials of young adolescents, actually as young as 13, have been included in these trials that really put buprenorphine in combination with behavioral therapy head-to-head against clonidine and behavioral therapy. And for example, some of the studies have determined that buprenorphine is not only highly efficacious, but that it's more efficacious than clonidine. And the outcome measures in those studies included abstinence rates as well as treatment retention and withdrawal symptoms. And those were all in the context of a 28-day outpatient buprenorphine taper. They also noted that buprenorphine was not only safe, but that it also produced significant decreases in risky behavior associated with HIV risk and significant increases in other psychosocial functionings. In some cases, I was actually just at a presentation last week, the conference of the Association for Medical Education and Research in Substance Abuse, where some folks from Children's Hospital in Boston did some presentations on their work with adolescents and buprenorphine. And it's important to know that they're using, at least in Boston, naltrexone as a valuable treatment adjunct after detox for some adolescents. Naltrexone doesn't have abuse potential, and it can help prevent relapse by blocking the effects of opioids. It's an antagonist, as we talked about before, if the patient relapses to use. So it's one of those medications where it's going to sit on those opioid receptors and block it so that any opioids that the patient would use would be, the patient would be unable to feel the effects. It has been a valuable adjunct treatment, but it's most likely to be effective for patients who have a really strong support system. So by that, I'm thinking specifically of adolescents who are going to have one or more people actively engaged in their life who can observe or supervise or even dispense the PO naltrexone on a daily basis. It's also available as an intramuscular injection that can be done monthly. So both of those are options, and they do tend to be used with adolescents and young adults who are only on buprenorphine for short periods of time. So one of the other special populations that we hadn't talked about yet are patients who are taking buprenorphine and then have either an acute or a chronic pain issue that needs to be managed at the same time. There are also some myths and misconceptions about how to juggle these two, or how to manage both simultaneously. The first misconception is that opioid agonists that people are receiving in a maintenance dose and a maintenance situation are going to provide pain relief. Pain relief really depends on maintaining somebody's established tolerance, so maintaining their current methadone dose, for example, with an opioid agonist, and then providing additional pain relief on top of that when you have an acute or chronic pain type of issue. It's really important to remember that people who have used opioids for a long time do have neurological changes in their bodies, and so the typical effects that you might get from standard doses of analgesics are not going to be adequate. And it may mean that switching to different opioid medications are going to be necessary to give people adequate relief. One of the second misconceptions is the idea that the use of opioids for pain relief is going to result in addiction or relapse. And that's a really common concern among primary care providers or people in general medical settings who don't have a good understanding of addiction. They often have concerns that people who need opioids for pain relief when they're already receiving opioid agonist therapy are going to automatically relapse. But there's no evidence that relapse rates increase when people are taking opioid analgesics in the context of acute pain. And in fact, you can imagine for a lot of these patients, the stress and the discomfort physically as well as psychologically from having pain that's not appropriately managed or is relentless and unrelieved is more likely to be a trigger for people than having adequate analgesia in a supervised kind of situation. The third misconception is that combining opioid analgesics and opioid agonist therapy is going to cause respiratory or CNS, central nervous system depression. And primary healthcare providers are sometimes unfamiliar with how to manage this and are concerned that it's going to result in dangerous levels of sedation for their patients. But this hasn't been clinically demonstrated, and in general, tolerance to side effects is going to develop pretty quickly. So doses of pain relief can be increased as necessary to make sure that people are receiving adequate pain relief. Oops. Sorry, I need to go back for a second. I skipped over the fourth bullet here. This is one of the main concerns that you see in both the acute care setting as well as typical outpatient primary care settings. There's a concern among a lot of providers that patients' reports of pain are disguised efforts or to be manipulative or obtain extra medication to feel that euphoric high. And it can be tricky sometimes to distinguish between somebody's desire to be adequately medicated for pain and this desire to achieve a high. And this can be especially true in patients who have become physically dependent on opioids because of the treatment of an original pain condition. And so it just really does require careful assessment to determine the appropriate treatment plan. There are some clinical features that help distinguish opioid use in people who have pain versus patients who are addicted to opioids, and I would encourage you to check out the TIPS series, specifically TIP 40, which is clinical guidelines for the use of buprenorphine in the treatment of opioid addiction. And you can access those online free of charge, or you can order free copies as well. So People who are receiving buprenorphine, who are having lower levels of pain, can initially be treated with non-opioid analgesics if that's appropriate. But if they're having acute pain that requires more than ibuprofen or some other non-opioid med, then they have to receive the usual pain management protocol, and that typically starts with short-acting opioid pain relievers. It's really important for patients to understand how their medication works, so that if they are in that situation and need to advocate for themselves, that they can explain to a provider that the buprenorphine needs to be discontinued while they're receiving opioid pain medication. So again, that's an important patient education opportunity to make that pharmacology and neuroreceptor information accessible to your patients, so that in the event that they need to advocate for themselves, they can at least get that discussion started. When you're initially inducting someone onto buprenorphine, again, you have to wait until sufficient time has passed so that any opioid meds that are on board already have cleared from the person's system, and you start to see those symptoms of withdrawal. But if buprenorphine is started before the person is actually in withdrawal, then you may actually precipitate a withdrawal that's pretty bad. People who need long-acting opioids for severe and chronic pain, say in the case of cancer treatment or serious and unrelenting complications from other injuries, may not be good candidates for buprenorphine in the first place because of the ceiling effects that we talked about earlier. We're going to spend the rest of the training just talking about some of the various approaches that can be used to treating opioid-addicted individuals. Some of this information, again, is buprenorphine specific, and some is broader. It's really important to discuss early on the benefits of buprenorphine maintenance treatment with patients, and with respect to evaluating whether or not they are appropriate for maintenance or for a detoxification taper, you need to ask the patient if they've had, for example, previous attempts at medically supervised withdrawal, and if they've been successful or unsuccessful in going that route. You need to also know whether or not illicit opioids are either avoidable or unavoidable in their current living situation, and how stable their current living situation is in general. It's also important to explain the issues that are involved in evaluating whether or not it's appropriate to discontinue buprenorphine treatment, and really make sure that everybody's on the same page. Ultimately, when you are collaborating with the prescribing provider, you need to have those ongoing lines of communication so that you can avoid interpersonal conflict with other professionals, but also triangulation by the patient. So when you're counseling buprenorphine patients, it's essential to address the importance of maintaining counseling and the different benefits that counseling is going to provide over and above the medication, or how the medication and the counseling work together in a synergistic kind of fashion, and really make those benefits explicit for the patient so that they're seen as equal components of an overall treatment program, and not counseling being seen as secondary to just ingesting a pill. If counselors start to suggest the need to discontinue medication, it can inadvertently send the message that the medication is a necessary evil or is somehow wrong. And so it's really important to refer to buprenorphine as a medication as opposed to a drug. Overall, we're pretty adamant about referring to it as a medication and making that very clear distinction between drugs of abuse which are bad and you would need to get off of, versus medication, which may be started or stopped or adjusted under the supervision of a physician. And it's important to frame that in terms of medication adherence, sticking to the plan, which is much different than, obviously, taking illicit substances at one's own discretion. Some patients are ambivalent or have mixed feelings about, or even totally averse to taking medication, and they may have gotten these perceptions or attitudes from either previous treatment experiences, methadone-related stigma, or from other people in recovery who they're familiar with who are using medication. It's not an essential modality for a treatment plan or for a recovery process, and we know that people can successfully be treated and retain sustained recovery without it. But it's important to talk with the patient about some of the very real concerns and the realities of withdrawal, and some of the low success rates of folks who try it without medical assistance. Counselors can help by really explaining all of the options to people, dispelling some of those myths about buprenorphine, and really providing accurate information about how the medication is used as part of a whole package. So again, I really want to commend everyone for taking the time to do this large chunk of a webinar to really gain additional familiarity with buprenorphine so that you can be advocates for your patients and all of the options that are available to them, because you may still have patients who are unsure of whether or not this is the right route for them. When you're counseling buprenorphine patients, you want to use many of the same strategies that you would use in counseling any opioid-dependent patient or any patient with dependence on other substances. You need to be flexible. Obviously, people's lives are typically out of control, and transitioning from active use into recovery is just a huge lifestyle change. People are typically late for appointments, or they reschedule, or they fail to show up altogether, and having overly rigid standards or overt and over-the-top expressions of disapproval are likely to contribute or exacerbate any negative feelings that people are having about counseling. And so it's important to consider that balance between maintaining the structure of the program and the expectations and appropriate guidelines for program attendance, and yet not turning patients off altogether with an overly rigid approach. It's also important to not impose overly high expectations. People who have made this initial step to pursue treatment and address their drug addiction have already made a significant accomplishment, and it's a major change in their life. And so expecting immediate or major changes may be unrealistic for a lot of folks. Those of you who are familiar with motivational interviewing are familiar with a lot of the approaches that are more patient-centered. For example, instead of being confrontational, it's often better to develop discrepancy in sort of where people are and where they want to be, or where they are and where they think they are, and letting that cognitive rub or dissonance in and of itself serve as a motivating factor, because we know that direct and really harsh confrontation are more likely to drive someone out of treatment than to engage them in the processes. We know also already regarding non-judgmental acceptance and viewing behaviors like lying and stealing and unreliability as really being symptoms of the drug problem and not necessarily someone's refusal to engage in treatment. Two of the other strategies that can be used are using the motivational interviewing or MI approach, and also providing reinforcement. I'll say more about those in a couple minutes. We've talked about 12-step programs. We talked about the benefit. We know most of you know the benefits of participating in 12-step as an adjunct to buprenorphine. One of the best features of 12-step programs is the enormous support and network of non-using friends that people can rely on and develop new relationships with. For those of you who aren't familiar with 12-step, in general, there are speaker meetings where a recovering person tells his or her story. There are topic meetings where people are discussing a specific topic or theme, like fellowship or honesty or acceptance or patience. And then there are also step or tradition meetings where specific individual 12 steps or individual 12 traditions are discussed. Some people are able to stop using substances through 12-step participation alone. There are lots of people who have gotten and stayed sober through 12-step modalities, but for other people, it's part of a package. It's part of a variety of things that they access and serves as a valuable adjunct to other pieces of treatment. Again, I would refer you to the publication which is listed here, the AA member medications and other drugs. If you need some additional ideas for how to help patients who may have had negative experiences in the past at 12-step meetings, one role that addiction professionals can take, again, is to offer a lot of the creative solutions that you all have come up with, but to educate patients about what the official position is of 12-step programs about the use of prescribed medication, highlighting some of the benefits of 12-step, and then promoting the use of these programs as part of people's overall recovery process. And some people may still opt to not pursue those, but it's helpful to encourage patients towards places where they will feel safe and accepted. So with respect to buprenorphine, one of the treatment approaches is the motivational interviewing approach, and also motivational enhancement therapy. They're both therapeutic techniques that I'm guessing a lot of you are familiar with that help people move quickly through the process of change. There is also a blending product put out by the NIDA-SAMHSA partnership, which is specifically on motivational interviewing assessment, and it can be found on the web. It does have a lot of the tools that can help folks who have baseline MI skills enhance those, and there are also materials for supervisors to help enhance the skills of your staff. And I would refer you to those two websites if you're interested in additional information, either as a practitioner or as a clinical supervisor. Imagining a lot of people are familiar with the principles of motivational interviewing. Some of the key features are expressing empathy, developing discrepancy, again, between where the person is and where they want to be, avoiding direct confrontation and argumentation, and supporting someone's self-efficacy for being able to make change. Some of the specific, I think they usually call them micro skills involved in MI, are asking open-ended questions, being affirming of where the patient is and what they're feeling, reflective listening, and summarizing and reiterating so that the patient knows that they've been heard and understood. MI can seem very simple in some of its specific therapeutic micro skills, but it really takes a lot of practice to be effective, and I would also encourage you, if this is a treatment approach that you've been considering to pursue additional practice or training. And you can also check out tip 35, which is enhancing motivation for change in substance abuse treatment. There is also some research on using motivational incentives to enhance treatment. Motivational incentives like things that are low-cost reinforcement, so prizes, clinic privileges, vouchers, those kinds of things that are delivered in conjunction with on-site urine screening. And they've been shown to promote higher rates of treatment retention as well as abstinence. So they're also another modality to consider as an addition to your treatment planning or your programmatic structure. There are additional blending products that are related to promoting awareness of motivational incentives and how to use these techniques effectively in your program. And again, I would encourage you to check out some of the other blending products that are available on the web through the NIDA-SAMHSA partnership. So here's some of the early recovery skills that we know are applicable to recovery approaches for other substances or for treatment plans that don't include medication. Early recovery skills, as I mentioned before, getting rid of paraphernalia, scheduling, dealing with developing trigger charts. Relapse prevention includes learning new behaviors, monitoring early signs of relapse, or identifying vulnerable states for when that can be more likely to happen. Understanding that recovery is more than just not picking up, and that it's about more than just not using drugs and alcohol at all. Other sample topics that can be included under relapse prevention curricula include overall overviews of relapse prevention, using behavior, ways that people attempt to justify relapse either consciously or unconsciously, identifying dangerous emotions or vulnerable states, being smart and prudent in lifestyle choices, where we go, what we do, and avoiding relapse drift. There are also other topics that would include whether or not your program is advocating total abstinence, the full-time commitment that it is to engage in recovery, and that it's often just as busy as the full-time job that addiction was, and some self-care modalities as well. Learning to feel good about your sense of self-worth, and taking some of those proactive actions to take care of yourself as opposed to just survive and get by and get through. Other important concepts are repairing and restoring relationships, being truthful, not just in what you say, but true to yourself, true to what else you need to do, and how that can serve as an effective defense against relapse. And then notions of trust as well. How to have drug-free activities and build new activities as well as new relationships, and then learning about stress and stress management and its role in relapse. Motivational interviewing typically goes hand in hand with the stages of change or trans-theoretical model of behavior change. People who enter treatment are typically at different stages of readiness for treatment and openness to engaging in counseling. And it's just important to remember that interventions that may be effective at one stage of readiness or for one particular substance may not be as effective when used during another stage. most of you are probably familiar with this model. The idea is that people make change incrementally and not in a linear pattern, but that they move through stages of readiness to engage in the change process. They go from pre-contemplation, where, say, making a change or addressing the issue is not even on their radar screen, to contemplation, where they're starting to recognize the need for change and think about how they might actually do that. Determination, which is also sometimes referred to as preparation, is when they've decided that they are ready to make a change and start taking steps towards that goal. Action is when the plan is actually being executed, and maintenance is when it's sustained. The important thing to remember is that this is a nonlinear process, and so people may, quote-unquote, fall off the wagon at a certain stage and then re-enter somewhere else. The other thing to remember is that that it is an effective and an important intervention, for example, to move someone from pre-contemplation to contemplation, that moving someone along that readiness is just as important. All of our patients are not going to be at the action phase for every substance and every issue. And so even within an individual's treatment plan, they may be at different stages of change for addressing different issues. I went through some of these definitions again. It just highlights various stages of readiness to consider and then act on making a change. And these conclude with action and maintenance. One of the things that I didn't mention actually when the diagram was there is that recurrence or relapse is an integral and assumed part of the model. And that's true whether you're talking about drug use or tobacco use or sticking to your diet. They're assuming that relapse is a typical part of that process. Someone is going to pick up again. Someone is going to go on a cruise and go off their Weight Watchers eating plan, but that the important thing is to help re-engage the person and move them towards action once again. So just to close with some final thoughts about buprenorphine, it's important to know that buprenorphine treatment works in multiple settings. Different trials that have been conducted through the Clinical Trials Network have demonstrated that buprenorphine treatment can be integrated into specialty clinics, hospital settings, and programs that are otherwise typically abstinence-based. And it can also be incorporated into settings that don't have a lot of prior experience using agonist-based treatment. So for those of you who are in rural areas that are far from urban centers or academic centers, we do know that buprenorphine can be incorporated into those non-traditional settings. At that point, though, it does become more of an implementation question and making sure that you have the organizational and financial and administrative supports, as well as having adequate staff and professional resources to help make that happen and sustain this type of program. Again, there are these really valuable websites for the addiction transfer technology centers, as well as the additional blending products that are available through the SAMHSA and NIDA partnership. In closing, I just want to again highlight that buprenorphine patients need to learn and need to learn that they need to learn the skills that are going to support their long-term recovery. So stopping those early drug thoughts before they become full-blown cravings, and really supporting that early engagement in treatment. Part of that early engagement also is making sure that a comprehensive needs assessment has been conducted by the treatment team so that all of those issues can gradually be addressed at the appropriate time. There are various ways to incorporate psychosocial treatment into the treatment plan for buprenorphine patients, and obviously you guys have found some creative ways for doing that, particularly in the context of 12-step programs. We know that buprenorphine has a physical and behavioral we know that opioid addiction has a physical and a behavioral dimension, and that while the medication buprenorphine is going to address the physical part, it's not going to adequately address the behavioral dimensions. And so the ideal buprenorphine treatment team is made up of the physician, the substance abuse counselor, or psychiatric advanced practice nurse or other person that can provide that counseling, as well as having folks on board, either on site or available through liaison services, who can provide the additional ancillary community support that people need. And then ultimately, the goal is to have this coordinated treatment that really helps support all of the patient's needs. So this actually concludes my portion of the training. I want to thank you guys again for taking the time to learn about this new option and find out exactly what the roles for non-prescribing providers can be in this picture. We have, let's see, about 12, 15 minutes left, and I'm happy to take any questions that you all may have.
Okay, we don't have any questions yet, and I did put up my screen then, just showing the title of the program again. Please, if you have any questions, type them in right now. If you have any questions afterwards, you can email me at pondk@ireta.org, and I'll forward those on. Tomorrow morning, everybody who's attending will receive an email from me, and for those who attended all 3 sessions, they will get an order form for the CEUs. Everybody will be getting an evaluation link, and we just really please ask everybody to click on that link and fill out the very short evaluation for this series of trainings. It is really important to us in our grant that we receive them from all of you. And while I've been talking, we have a couple questions that came up here. Let's see, one of them is, I just wondered if it's possible to mention to the audience that Holy Family SOARS, S-O-R-E-S, program offer therapy for clients needing to meet suggested sessions. We provide in-home therapy, and the number, so this is in Pittsburgh. The number is 412-361-1083. That's the Holy Family, S-O-R-E-S, SOARS program. Now here's a question. How long is it recommended for a maintenance program?
So the question is, how long would the patient need to be maintained on buprenorphine?
Yeah, it's how long is recommended for a maintenance program, right? They don't go into specifics. Maybe if the person will email a more detailed question, we can find out a little bit more.
Yeah, I think the short answer to that would be that there isn't necessarily an ideal, that it's really going to be patient-driven, and that in some instances there may need to be long-term maintenance. For other patients, it may be appropriate to consider a detox. It really needs to be on a case-by-case basis.
That's correct. There's no specific time yet as to how long one should be maintained on the on buprenorphine.
I mean, if we think about it as analogous, to other medications, say insulin or oral hypoglycemics for diabetes, in some ways it's like asking how long someone would need to be maintained on insulin. It could be the rest of their lives, or it could be, depending on what else is going on in their treatment response, what else is going on with the other changes that they've made in terms of their diet, their lifestyle, their weight loss. The doses may need to be adjusted, and someone may ultimately be able to come off their diabetes medication. In other cases, they'll be on a dose or on a low dose for the rest of their lives. So if we truly believe that addiction is a chronic disorder, then you know, that would mean that a parallel approach to some forms of medication-assisted therapy may fall out along the same lines.
Okay, here's another one. It was noted that younger persons may need a longer program than standard, but it doesn't say what is standard. Is long-term considered to be months or years? Realistically, is there funding for lifetime treatment?
That's a really good question. I am not sure what the longest period of time is that insurers would be willing to continue to cover this, particularly for adolescents. Does anyone else in the audience have a perspective on that?
Is this about the coverage for the medication itself? If that's the question, I think it's like any other medication that the insurance covers.
Did we adequately answer that question?
Yes, she says it is about the medication.
So is it about, I'm sorry, is it about the medication itself in terms of what an appropriate duration is, or is it about the likelihood that insurers would cover it over an extended period of time outside of some predetermined time frame? I just want to make sure I understand.
Yeah. Okay, Cindy, let's get some more information here. Hopefully she'll write. Oh, here. It would have to be more than the medication if they need ongoing counseling while on the meds. So I think she's just asking for insurance limitations, and if you have any idea if the client really needs to have the counseling and medication for a long period of time.
I don't think there is any specific limit as to the counseling too. I mean, it will depend upon who the counselor is and the individual treatment plan. So initially, if somebody is requiring more frequent contacts with the counselor, over time that may be less frequent. But there is, I don't think there is any specific number of sessions or number of years or number of months that one will be authorized to have counseling. And as in terms of the medication, it's like any other medication that it may be approved for a year and may have to be reauthorized, but there is no limit as to how many times or how long the person can be on the medication.
Okay, well, nothing new has come up, so I guess this would be, we could, here's another one. Most MCOs have limits on the authorization for services. If a client is on Bupe for years, it is possible that the client's MCO would no longer pay for counseling. This may be the issue.
So the MCO would be making the assumption that the medication in and of itself would be sufficient and they don't need to provide counseling services?
And that's what it's sounding like.
Yeah, and I had heard of I mean, again, this is definitely, the world of managed care is definitely not my realm. So if anyone has additional information, please feel free to chime in on that. But I have heard of instances where the managed care organization policies are actually counter to the actual recommended treatment package.
Here's a new question. Can clients on Suboxone continue to use opioids and feel the high while on maintenance treatment?
Typically, no, again, because that buprenorphine is going to be sitting on those opioid receptors, and it binds much more tightly than pure opioid agonists. And so the idea is that it's essentially occupying that seat and is not going to come off easily. So when the other opioid molecules, say from the Percocet or the heroin or whatever, come along, they're not able to attach to that receptor site and give people that euphoric high?
The person who is sending the message before about the length of time for the insurance, they said in order to get scripts filled for medical assistance clients, they must be in counseling.
So it sounds like the federal government has a different
MCOs
approach.
that in this region in that we work here around Pittsburgh, they require that the members who receive buprenorphine should also be in counseling. So that's something which the prescriber who is giving the buprenorphine should refer these individuals to counseling.
And in that instance, would attendance at 12-step count as counseling? I mean, I understand the distinction, but I'm just wondering how the government sees that.
I think the 12-step is not paid for. Most of this, some of the information that we get is from the claims data, that a service is provided and a claim is made for the service, and so the information can be derived from that. But if someone is, to the best of my knowledge, if someone is attending 12-step, if the counselor or the physician who's prescribing thinks that that is adequate, and I think some insurance even require some of the physical health insurances that provide the pharmacy benefits require that there should be a proof of that.
Okay.
I'm getting an email saying no, that it must be counseling in a licensed program or with a licensed practitioner.
Some may require that, yes.
Oh, that's for Pennsylvania. They write it. Okay. I'm not seeing anything else, so we can close this now, and I will have my email address on the information that will go out to everybody tomorrow morning. So if there's any follow-up questions, I'll just forward them on to you, okay?
Thank you very much. Thank you, everyone.
Thank you all.
Okay. Well, at this time, we will be closing this session on Monday. This Part 3 and also Parts 1 and 2 will be on our website for on-demand viewing.
The organizer has